And it is my very pleasant duty next to introduce Dr. Kodithuwakku, who is a senior registrar in nephrology at the National Hospital of Sri Lanka. Gatika and I have worked in the same ward for a long period of time before he became a nephrologist. He has the usual MBBS, MD, so on and so forth. And then he has an interest and he has many research presentations, including the best research in 2019 in the Gall Medical Association, as well as a registrar he won. We have something like the Young Physicians Forum in the Gall Medical Association. It's called the Young Specialist Forum, and Gatika won the prize for that. So in addition to that, now Gatika is going to talk about dialysis in the power play of critical illness. The topic itself conveys Gatika's other passionate interest, which is cricket. Gatika plays for the CCP cricket team and has done very well for the CCP over the years in the cricket team. So he has brought his cricketing thoughts into his nephrology thinking as well. So we're going to listen to him about the power play in critical illness and the role of dialysis in that. Over to you, Gatika.
Thank you very much, sir. So I suppose it's a good afternoon and everybody probably have enjoyed their lunch or maybe expecting to do so. So here I am planning to discuss about something very important when it comes to critical care in our setup, because we do not find patients only in ICUs when we talk about critical illnesses, because sometimes you find critical patients without an ICU in your normal wards and maybe in corridors as well. That's our setup, and we are working very hard at the moment. And I believe that some of this knowledge that I'm going to give you in this lecture will help to manage and maybe to save a life in the future. And we are in some dire circumstances as a country at the moment, and I'm certainly going to shed some light. I hope this lecture will shed some light at the end towards that situation as well. So, well, the image shows a war, and war is somewhere you are having a very little idea about what's going on. If you get someone injured in the war field, it will be very difficult to treat. And so something like that will be happening in acute kidney injury in a critical patient, because so much is going on inside the body. It will be very difficult to isolate and think about a single thing. So I am not a war veteran, but as Sir has mentioned, I play a lot of cricket. So I love to start with that point. So I think everybody knows about a power play if you have seen a cricket match, because if you have not, it is the time to watch a match today evening with Australia, Sri Lanka is about to go on. And there's something called power play in every T20 match and in one-day matches. So this power play rules for like 6 overs, and during that period, either batsmen or maybe bowlers can do very well. So the approach is, as field restrictions outside, that means only few number of people will be outside fielding, like 2 people. So if you can hit well over the inside field, you can score very high. At the same time, that comes with a risk. So if that risk is something that you're prepared to take, you can take it, but there's a good chance that your wicket may be at risk. So dialysis during critical illness is something like that. I hope that I will be able to emulate my example during this lecture. And in this lecture, I think these are the areas that I will be able to help you in your management in your future. So I am going to go through about some idea of kidney support therapy. So it is basically not only hemodialysis that you are seeing, that we usually call as intermittent hemodialysis. And I'm not going to go too detailed into the technical aspects. This is going to be something that is targeting general physician population and everybody that is practicing as medical officers in Sri Lanka. So the thing is, what is special about critical ill patients and the acute kidney injury, and what is the best approach? So what you usually see is when creatinine starts to rise, you will definitely contact a nephrologist or maybe the best person that you can contact, because you're worried now whether this patient is going to need dialysis or is it going to help. So if I am going to start dialysis, what is the best time? And is it now, or should I wait until something like high potassium or severe acidosis to happen? So I hope that I will be able to answer this question by the end of these 30 minutes. So go through some rough details. AKI is so common, and as a rough figure, out of a million, about 2,000 to 3,000 will suffer acute kidney injury during a year. So out of those 2,000 to 3,000, about 10% will need some sort of a kidney support therapy. So the kidney support therapy is mainly used in critically ill patients, and a large number of critically ill patients will need kidney support therapy. That means the forms of dialysis that you know as intermittent hemodialysis, or maybe CRRT, or maybe other variants. So the idea about this lecture is to get you through the current detail and the research that says what is the best approach in such a situation. So whatever the acute kidney injury, whether it is needing kidney support therapy or not, the first thing is to look at the etiology and to try to correct that, whether it is an infection, maybe dehydration, maybe a part of multi-organ disease. So try to correct that. Then to address complications and to decide whether they will benefit from some sort of a kidney support therapy. So as I said, critically ill patients are very difficult to define. Other countries will say those are the patients who are in ICUs, but in Sri Lanka it is not so. So I think everybody has their definition about critically ill patients. So I would say those are the people who have a lot of issues going on and at a certainly high risk of losing their life. And when it comes to acute kidney injury, they say about 40 to 50% of people who suffer from critical illnesses, either due to surgeries, traumas, sepsis, or whatever the reason it is, about 40 to 50% of those critical ill patients are going to suffer from acute kidney injury of some degree. And if that acute kidney injury is going to need renal support, there's a high risk of death even beyond this 50%. That approximately reaches around 70% according to the current available research evidence. So I know that everybody is very familiar with the staging of CKD. So you'd say CKD stage 3, 3A, 3B, 4, and 5, and so on. But very little number of doctors are aware that there are stages for acute kidney injury as well, because that's very important. The patient who has a creatinine of 2 will be very difficult to evaluate when it comes to the degree of kidney injury they are suffering. So this is KDIGO's proposed stages of acute kidney injury. It actually looks at the creatinine value as the multiplication from the baseline. So if it is stage 1, 2, or 3, can be referred. So obviously, when it advances to stage 3, critically ill patients are going to have a very high mortality. So this is one of those charts that I have found in American Journal of Nephrology. So it shows very clearly that, let me show you with it's a pointer. So the people who does not suffer from kidney injury are more likely to recover, but the mortality gradually increases up to 43% at the time that they reach acute kidney injury stage 3, that is tripling of their creatinine value. And to say that is anyway invariably going to cost a lot more to manage a patient with acute kidney injury compared to a patient who is not suffering from renal impairment during the critical illness period. So that is going to increase the cost, and it's going to bear a burden on the economy of the country. So the other important thing that we should notice is that sometimes you will be looking at creatinine, but the kidney injury is already there and had been there for about 24 hours more, or maybe 48 hours, because creatinine is a functional marker that is going to rise over next day or so, because kidney injury is already there. So you may be thinking, okay, the creatinine is not rising. So is it important to look at something else? You know, creatinine is a good functional marker. So things will happen after 24 hours. Is it important to see? So this interesting study done in 2008, which was published in American Society of Nephrology Journal, shows the answer. So it was done with a mouse, and what they did was they anesthetized the mouse and clamped its renal arteries. So what happened was they checked what is the time that mouse will start to run around the box when it recovers from the anesthesia. So they have noticed, as you see here, that this is the sham, that means the control one. The control mouse started running immediately after it recovered. But this is the duration of renal injury that they inflicted. If the artery was clamped for 45 minutes, the mouse started running a little late. And once the artery was clamped for more than 1 hour, the mouse actually took a longer period to start its activity. So that shows that acute kidney injury, even though it takes time for the creatinine to rise, is going to impart its effects on the body immediately once it's there. This is one of the other studies that did the same. So what they did was they did this functional nephrectomy with the renal artery ligation in the mouse, and they checked the methylene blue extravasation into the GI tract. So you will easily see what has happened. So the intestinal blood barrier is intact in the control subject after 5 hours. And after 5 hours from the functional nephrectomy, the methylene blue was extravasated into the GI tissue in the other mouse. So that shows that even though we expect the renal injury complications to happen sometime later, body is going to suffer with those lack of clearance of inflammatory markers and so on and so forth immediately after this has happened. So the other important thing as a baseline for us to note is there's something called organ crosstalk, because kidney is related to almost everything in the body in regards to its homeostasis, and it is a very important organ when it comes to critical illness. So if you lose the kidney, there's a good chance that you're going to lose the other system. And kidney injury, I would say, if it is, if you know, multi-organ dysfunction syndrome is a group, kidney injury is the group leader. It's almost always there. So it's very rarely you will find a multi-organ dysfunction without kidney injury. So these are the common syndromes that you may be already aware, which are very common among renal syndromes, critically ill patients when it comes to renal injury. So you will notice cardiorenal syndromes, hepatorenal syndromes, a lot of acute tubular necrosis, and even contrast nephropathy, which is a very dangerous condition in critical people. And there are a lot of other conditions as well. So the other important thing is whether dialysis can help in these critically ill patients with acute kidney injury. So as I have already noticed, the kidneys are going to play an important or vital role. So definitely it's a no-brainer to say that they are going to need kidney support therapy. So this is a simple illustration of what it looks like to be dialyzed, or maybe to be connected to one of those circuits. And this is the simple basis. And what you do is you take blood from the venous end here, and you run it through a machine. And this is where the magic happens. And that's called a dialyzer, where your blood is clean and the blood will enter back into your body through a veno-venous port. So this dialyzer is going to do this. So this is that part that if you have seen a dialysis machine, I thought this would be important, because a lot of people send patients for dialysis, but they rarely get to see a dialysis machine and get to understand what's happening inside. So that will help them to get a better idea about their patient management of some sort in the future. So this is that dialyzer membrane where there is this. So this is a synthetic membrane where it allows diffusion and convection to take out the unnecessary solutes in the blood and to remove it through fluid. So that is the basis. So the other idea is, should we dialyze everybody? So if the creatinine is 2, whether it is 3, 4, 5, 6, even if it is 10, should we dialyze everybody? So theoretically, these are the things that is laid out in most of the guidelines. So you are going to dialyze if patient has severe pulmonary edema, which is very resistant to diuretics. And if the patient is having severe hyperkalemia, ideally above 6.5, or maybe with ECG changes, it is difficult to control with insulin, dextrose, or whatever the thing that you are going to use. Or maybe severe metabolic acidosis, or maybe complications of uremia like pericarditis and encephalopathy. So these are the definite indications for hemodialysis, and maybe certain drugs or toxic substances can also be a definite indication at different points. And rarely people will use dialysis for conditions like where you need large volume of fluid administration, such as in nutritional support, maybe in massive blood transfusions, and conditions where you will have some problem with fluid volume control. So you can take some fluid out with dialysis machine. But the real thing is, what is the real issue with the critically ill patients? Because they are already having compromised hemodynamic status. They are going to be benefited with removal of uremic toxins, support of electrolyte balance and fluid balance, and even dialysis can help modulate cytokine levels, because if you dialyze, the cytokine levels are going to be cleared. So the cytokine storms that may be imparting its bad effects or harmful effects in certain patients are going to be invariably benefited. And it's definitely a platform for multi-organ support. But are all critical patients are going to benefit? So it's a two-way sword. Maybe I would say it's a double-edged knife where you can easily cut yourself, right? Because it can easily trigger, which is the most worried complication, which is hemodynamic instability in these critically ill patients. Most of them are on inotropic support and they are hanging on the edge. So if you are going to take about 250 ml out within a minute for the dialysis and to continue that for like 4 hours, what will happen? So you are going to induce some hemodynamic changes in the body that body is already struggling to compensate for. So it will be very difficult for certain patients to tolerate these hemodynamic changes. So there are different modalities like continuous renal replacement therapy and slow low efficacy dialysis, sustained low efficacy dialysis. So those modalities are there, but still that are still going to impart some effect on the patient. And there may be electrolyte changes, and you are going to use heparin. So if patient is already having some bleeding tendencies, that is going to be a big problem. And if heparin-induced thrombocytopenia is going to occur, that's going to worsen the matters. And on top of all that, there are line-related complications. You need to get a line in despite lower platelet levels, high bleeding risk and all. And there's a chance of propagating thrombosis as well, and infections which can occur with the line. So knowing all these complications, is it important to initiate kidney support therapy, and when is the best time? This is the final and most interesting part that I can give you some knowledge on. So the same question appeared to a lot of European scientists and doctors, and they formulated several trials. So what they did was they conducted several trials in different centers and came up with some answers. So this is something that I should say. At the moment, the latest one that guides us for the initiation of dialysis is the last conference of Edigo controversies, which is the authoritarian body for our academic matters when it comes to nephrological management. So they have recommended to consider dialysis when the demand of metabolic acidosis and other changes exceed the capacity of kidney to maintain the homeostasis. So even though it is theoretical, it's very difficult to understand in different patients when it comes to individual scenarios. So we'll move on to those trials and see what has happened in those trials. So what they have checked was they checked whether it is important to start dialysis early. Is there any benefit of starting early compared to late dialysis, or maybe expectant management? So by early, what they defined was they would start dialysis in most of the patients who are thought to have progressive renal failure and are going to need renal failure support in the future. So they use those AKI staging system and they started dialysis. I'm not going into details about most of these trials because that would complicate this 30-minute lecture. But I am going to give a rough idea about what has happened and which will be more beneficial than going into deeper numbers. So the expectant management was they waited until some real indications appeared, like high potassium level or severe acidosis or fluid management issue with pulmonary edema. So this is the first trial that I'm going to elaborate. That's ELAINE randomized trial, which was most of these trials are randomized trials, so meta-analysis. So this ELAINE trial was conducted in France, and that has shown this. So what they did was they randomized their patients and dialyzed early and expectantly. So what they have noticed is that it's a relatively smaller trial when it comes which compared to the other trials. So they have noticed some degree of a mortality benefit at 90 days with the early management. Here you are seeing the mortality percentage at 90 days, and by 90 days there was a small percentage of mortality benefit compared to the delayed management. So Elaine said early is better. So the recommendation was the available evidence starting dialysis early may have some benefits. But the other notable thing was that they had a fragility index, something called fragility index of 3. That means if 3 patients from this early group is moved to delayed group, that is going to change or alter the result of the trial out of 200 odd patients trial. So you understand that is a very thin margin when it comes to the final conclusion in this trial, right? So then I am going to talk about this Akiki trial, which is a similar trial with a larger number of patients in a multi-center setup, and it has shown very clearly that early stage management was similar to delayed strategy management. So if you are going to implement kidney support therapy early, it was almost similar to delayed strategy. But what is more important to note is that there was a difference of utilization of facilities. The outcome was similar at 90 days. So everybody was agreeing that point. But the dialysis was free for a large number of people, and the group that underwent early dialysis required prolonged duration and larger number of dialysis by that time of 90 days. So this is the same thing. And I'm going to brief you through some of the other trials that have shown the same thing, that is ideal ICU, and that was done in septic shock patients in France again. And ideal ICU has shown the same thing again. The expectant management was similar to early intervention when it comes to initiation of dialysis. And they have also noticed that there's a large percentage of patients who did not need dialysis at all in the delayed strategy group. So you understand. So if you are going to start dialysis, this 38% are going to be invariably dialysis dependent until the point either they die or at the time of the discharge. So the other 2 trials, START AKI and another meta-analysis, has also showed the same thing. And the final conclusion in all these trials was that expectant management was better, not superior to earlier intervention, and the early intervention actually increased the utilization of facilities. So the final idea that they gave us is that you can wait, and if you think on patient by patient basis that this is the point that they are going to need dialysis, then you can start rather than starting very early in the management. So this is another trial that is called furosemide express trial that will help you to take that decision, because and then they have noted this is also part of those trials that compared early versus late. And the additional thing is in this furosemide stress trial was that they used a shot of furosemide to see whether there is a response with regards to the urine output. In most of these people, that may be directed towards dialysis. So if they noticed about 200 milliliters of urine production after 1 milligram per kilogram bolus in furosemide naive patients, or if the patient is already on furosemide, 1.5 milligrams per kilogram bolus was given, and they have noticed by the end of the trial, the people who responded to this furosemide shot went on to give these results. So these people who responded did not need, 86% of the people who responded did not need dialysis by the time they recovered. Only 14% needed. And non-responders who did not produce urine needed 75%. So that clearly indicates that this can, maybe that is not a clear indication and a guide, but at the moment, that is a supportive tool for your clinical judgment. So you can see whether furosemide is going to help. So my final slides would say, how should we implement this? And in our setup, how can we use these important vital data for resource management as well as managing individual patients? So it is very important to understand that this is a very fine balance between an unnecessary procedure and a life-saving procedure. So you should be very careful when you take those decisions. And when you are going to manage expectantly, you need to look a little closer. And also they have noticed when you manage with expectant approach, you are going to need a little bit more other supportive therapies like high loads of diuretics and other supportive care compared to the earlier group. So knowing all this, we'll be able to manage our patients well. So as a summary, I would like to say there was a significantly higher mortality rate in most of the critically ill patients, particularly if they develop acute kidney injury. So kidney support therapy is going to be a marvelous thing that is going to help their lives if they can be saved. And the trials are currently showing there's a little bit, difference when it comes to proactive therapy versus expectant therapy. And again, it shouldn't be delayed if there are clear indications to go ahead with the dialysis, or maybe whatever the dialysis sort that they are going to be benefited from. And in Sri Lanka, this expectant management can save vital resources, particularly in this setup where we are struggling to get down most of those facilities and things that we need to continuing our dialysis program. And furosemide stress test can be a good help in most of these situations where you are managing a critically ill patient. Open to that.
Thank you, Gatika. Thank you very much for that presentation. Thank you, Gatika. I'm sorry, may I request Dr. Bharatna and Dr. Jayanagar to direct any questions that they may have, please, towards Gatika. Thank you.
Yes, thank you. Thank you, Arosha. And it's a excellent exposition for the non-expert, in renal disease, renal nephrology. Now you said there is a expectant management is probably as good as Are you saying that we should still accept the standard criteria for severe acidosis, severe hyperkalemia, that type of thing?
Yes, definitely.
In most patients, rather than starting early dialysis. Are you saying that in practice? Are you saying in practical terms?
Current evidence suggests us definitely that trials did not compare that. Actually, what they did was, if there are those clear indications such as severe acidosis, severe hyperkalemia, they didn't wait. They were actually not part of the expectant management. What they did was they stayed until if either that happens, or if that means if hyperkalemia or severe acidosis happens, or if they think that this is a situation where a patient is already going to head towards hyperkalemia or severe acidosis, then they started. That is expectant management. And early management was when they noticed stage 2 acute kidney injury or maybe late stage 1 acute kidney injury, they started dialysis very early because they have enough resources. And even here we noticed that definitely without definite indications, we are getting referrals for dialysis. So I think this will help, this lecture will help those people who refer us and manage these patients to understand when a dialysis would be important, rather than looking for a creatinine value to guide the need of dialysis.
So do you think that you should develop some sort of guidelines for where early dialysis should be carried out in this type of situation? Some sort of guidelines for that.
Yes, we are currently latest guideline for those directions is 2012, and this KDIGO controversy conference occurred in 2020, and there's an upcoming guideline for dialysis directions. At the moment, the recommendation is to judge each patient in individual basis. If those definite indications are there, definitely go ahead with kidney support therapy with available resources.
One other question, just from lack of my knowledge. Sometimes I find nephrologists carry on continuous replacement and sometimes intermittent. Is there any benefit, any difference in those two kinds of dialysis?
That's a very good question, sir, because I actually wanted to highlight that point at one stage, because now there are research in comparing between intermittent hemodialysis and there's this thing called prolonged kidney support therapy, such as SLED, which is sustained low efficacy dialysis. and CRRT, which is continuous renal replacement therapy. So the difference is you are going to select different patients. If the blood pressure is good, hemodynamically stable, you can do intermittent hemodialysis. But when the blood pressures are low and patient is in a vulnerable situation, you are going to use lower volumes of fluid suction. So those are the CRRTs and SLED. So what they have shown is this intermittent dialysis and longer therapies are not associated with the advantage. And the selection should be on individual patient basis. There's no difference when it comes to mortality benefit in different therapies with the current evidence. And in fact, they did a trial comparing SLED and CRRT about 3 years back. That was a randomized trial. I can't recall the particular name. That trial clearly showed that SLED or slow dialysis is equally efficacious to a CRRT, where we will be using a lot of resources and it will be very expensive.
Thank you very much. Thank you. Thank you. Very good.
Dr. Jayanaga, do you have any questions, Dr. Jayanaga?
Yeah. Yes, I have 2 questions to Dr. Gatika. For that excellent talk, I congratulate you. First, and my first question is like, having high, like somebody with rhabdomyolysis or a crush injury to arm or leg or something with a high CK levels, how far this will interfere with the creatinine values? Will it be like reflected in the creatinine and then we have a wrong assessment of the exact kidney function on that? That's my first question. Yeah.
Yes. So for that, so that's a very good question, because that's the situation that clinical science comes into play, because it's very difficult to in such a situation. Potassium will be released, creatinine from the muscles will be released. So we are going to go with creatinine and potassium because now we are going to have impedance. So basically what we do is that if in other countries there are things like NGAL where you can particularly look at the kidney function, but here we don't have those facilities. So things are mainly clinical judgment based. And creatinine is a very difficult thing to go by at that period, but urine output is a good one. So the duration of the injury, if it is less than 24, maybe 48 hours, we would still think of hydrating well and trying to clear some of those myoglobins. But if things are presenting late, it will be more towards low urine output status and acute kidney injury. So in that case, we manage that way.
Right. The second question is very quick one. You just said the furosemide challenge, like trying 100 milligrams or something. Is that what you mentioned?
Furosemide stress test.
Stress test, yeah. So will that be a bit harmful also in the setting of acute kidney injury? Because we believe that furosemide can be a bit toxic to the kidney.
Yes, sir. That article clearly mentioned that there was no difference between the intents. Now they did this as a part of a randomized trial. They clearly said that this furosemide challenge is not going to interfere, because furosemide in high doses can be toxic to kidney. That's a very clear thing. But this furosemide challenge test doses did not harm patients, and that actually helped us as a guide for the management of this patient when it comes to the requirement of kidney support therapy. So that is a cheap alternative and to support your clinical judgment, which will be very important in management.
What is the dose you recommend?
They have used 1 milligram per kilogram for patients who was not on furosemide. If the patient is already on furosemide, that would be 1.5 milligrams per kilogram. So that would be 50 or 75 respectively for a patient who's not on and on furosemide.
Right. Thank you very much.
Thank you, Gatika. Again, thank you very much, both for the presentation as well as the answering of the questions with clarity. There are a couple of other questions. Unfortunately, we are unable to take those on for the interest of time. May I try to see the certificate which we are going to present to Dr. Gatika Kodithuwakku on screen, please? Gatika, this will be emailed to you anyway. Thank you very much again for being part of this program. Thank you very much.